Happy New Year. Welcome back. Well, no, you never left. You guys have been here, right? Today is the monthly Global Health Series, and it gives me great pleasure to introduce Kavita Ramdas, who is now on the Stanford campus. Kavita has really spent her entire life working on issues of gender equality and human justice. She's a graduate of Mount Holyoke College and got a degree in public policy from Princeton University, the Woodrow Wilson. But she served as the president and CEO of the Global Fund for Women from 1996 to 2010, which grew under her leadership to become really the largest public foundation for women's rights. In fact, she grew its assets, I found this amazing, from 3 million, I think some of you got this little blurb, from 3 million to 21 million, really giving women in more than 170 countries access to financial capital to raise themselves out of poverty. She's currently chairs, and I want to hear a little bit more about this, the newly formed Women in Public Service Initiative that Hillary Clinton has started at the U.S. State Department. We're very happy to have her on campus at Stanford because she is starting a new program here called Ripples to Waves. And it's a program on social entrepreneurship and development of Stanford University. Well, it's on social entrepreneurship, and it's at Stanford's University FSI and the Center for Democracy and Law. And really, I'll just give you a few ideas of some of the boards she serves on. She serves on the boards of trustees of Princeton University, Holyoke, Rockefeller, Planned Parenthood, and African Women Development Fund in the USA. I really asked Kavita to come today to talk to us about some of the health issues that face women globally. I asked Kavita to make this as interactive as possible, and so if you have any questions for her, throw them out there. I also asked her to give us not only what the egregious issues are for women globally, but also to talk to us a little bit about your career, because you've had such an interesting career, Kavita, and I'd like to hear a little bit about us. We just interface on a day-to-day basis on social issues around Ripples to Waves. Anyway, my pleasure to introduce you.
Thank you. Thank you very much. Yeah, no, I'm good. Hi, everyone, and thank you very much. You know, it's sort of funny that I would be in any position to talk to any of you about career, because I was just confessing to Michelle that I went through most of my childhood dreaming about becoming a doctor, and you know, had the kind of childhood in which, at least growing up in India, that dream was pretty much you know, put to rest at an early point. In India, you have to actually have enough science to be able to get into the science stream in 10th grade, and then after that, you know, if you make it, then you get into one of the big. It's just as you hear more about the IITs in the United States, because now engineers are a big deal because of Silicon Valley, but Indian medical colleges are just as difficult to get into, and they're really hard to, you know, you sit the exams, and anyway. So I'm very honored to be with you all. I'm very honored that Michelle invited me to be with you. I want to tell you a little bit about the fact that the perspective that I would be sharing with you is very much a perspective of someone who has been an activist and a practitioner most of my life, rather than someone who is either a medical doctor, as all of you are, or as somebody who is an academic who kind of researches and teaches. And so much of what I will be sharing comes from a perspective of the work that I have done, both in the 14 years that I led the Global Fund for Women, and prior to that, almost 10 years of working on issues of urban poverty and inner city underdevelopment in the United States. And I say that because I think often when we talk about global issues of health and global issues of development, there is an automatic assumption that what global really means is outside of the United States. And I'd like to begin by kind of trying to ground us within the realities that, as someone who grew up in India, I certainly did not expect to have my first site visit in Chicago be to walk into a community where maternal mortality rates were higher than that of Bangladesh. And that was in Cabrini Green, which is a public housing project in Chicago in the sort of late 90s, 1988, 89. I was soon to learn that there were other statistics that were similarly grim. Infant mortality statistics, for example, on the south side of Chicago, which were easily comparable to those of so-called developing countries in different parts of the world, and sort of stunning to me in the context of one of the richest and most powerful countries in the world right here in the United States. And I think it's incredibly important for us as people who are studying and practicing medicine and or anything else in terms of being able to make a difference in the world, to remember that the United States, for all of the desire amongst current Republican candidates and otherwise to be considered exceptional, is very much a part of the globe. The United States is as much vulnerable to and responsive to and connected to the realities that influence the rest of the world as well. And one particularly stunning example of that most recently for me, I don't know how many of you saw the recently released statistics by the Center for Disease Control about the persistence of violence against women as a major public health threat in the United States. 1 out of 5 women in the United States is physically abused by, most likely by an intimate partner in her experience. And 1 out of 4 women in the United States has experienced sexual abuse of one kind or another. That's in 2011, or now we're in 2012, in one of the so-called most industrialized, most developed, most advanced, most, all those wonderful adjectives. And I think it is important for us to situate, my comments about how I see women's health in particular within this larger context of the fact that I don't believe any of the things that I'm saying are unique only somehow to the developing world. Of course, there are things that make the experiences of women in different parts of the world, in different cultures, unique and different. But what I want to begin a conversation about is the whole notion of how the health of women is situated within another larger and very much more important reality, which is the lack of power that women have in their daily lives, in their families, in their communities, and then more broadly within workplaces or governance. And this sounds difficult to believe in a context of the United States, certainly where women are now the majority of graduate students. I believe, I may not have this statistic right, but you guys can tell me, they're the majority of students in medical school, if I'm not mistaken. They are, we were just having a conversation. I have a 18-year-old daughter, and we're having a conversation with her and another friend, and they said, well, academically, we don't feel any discrimination at high school. And I said, academically, so do you feel any discrimination in high school? Well, socially, it's different. So we pushed a little bit more, and Mira said, well, okay, I don't understand why girls who take honor classes during the day dumb themselves down at night so that guys don't think they're too stupid, they're too intelligent. To me, it's very disturbing and a profound truth about how I've looked at the questions of women's health, that you can't separate it out. It's not that women's health is in a box over here called health, and everything else called life and work and war and education is somewhere in some other boxes. And it's in the same way that I think a lot of people have said to me when they meet me, oh, you spent most of your life working on women's issues. And I always ask, what are those? What are the set of issues on which 50% of the world's population gets to check yes, and we check out of everything else? And nobody asks if this is a men's issue. You don't have meetings and gatherings for men's issues, because the assumption, and people used to ask me this when I led the Global Fund for Women, is, oh, is there a Global Fund for men? And I said, yes, pretty much every financial institution in the world is a Global Fund for men. This is important not only because I'm being a little bit facetious, but because the location of questions about what are the most compelling challenges to women's health today are very squarely grounded in this sort of very profound and continuing inequality that exists. And as I suggested earlier, I don't believe that that is true only in the context of what we think of when we say the developing world. And even that term is highly suspect when you think of the wide range of countries from Burkina Faso in West Africa to places like India and China, which certainly have within them both developed and developing. And I think it is probably much more accurate to speak of developing worlds, both within countries and across countries. And I think that would probably be a more accurate way to speak, because how many of you have spent any time on an Indian reservation in the United States? Okay. My first visit to a Native American reservation happened when I was working at the MacArthur Foundation in the 1980s. And again, much as I was on my visit to the south side of Chicago, I was stunned by what I learned about fetal alcohol syndrome, about domestic violence, about abuse, about very, very high levels of alcohol abuse and physical violence on Native communities, and a whole host of other related medical issues that included high diabetes, very poor nutritional levels, et cetera, which were then all compounded by a set of profoundly important and interconnected mental health issues. So enough said about that point. You get what I'm trying to say. Let me back up a little bit and tell you a little bit about how I came to the Global Fund for Women, which Michelle so kindly described. I certainly was very proud to be a part of being able to take the Global Fund to the next level, but I certainly didn't do it alone. Nobody does any of this work alone. So I had a wonderful team of people. But how did I come to be involved with these issues, and what do I see as sort of the pressing challenges for women's health today? I came to work at the Global Fund for Women in part out of my work on poverty and underdevelopment at the MacArthur Foundation in Chicago, which, as I said, I didn't go into thinking that I would end up working on or focusing on the question of gender inequality. And yet, it turns out if you work on poverty, both in the United States or anywhere else in the world, you immediately find yourself focused on women and their dependent children. That's because women and their dependent children make up 70% of who's poor, both here in the United States and outside across the world. What that does then is to posit one big major health threat that all of you as doctors may think of as being a very obvious one, but it's becoming more and more pointed as our world has become more and more unequal. So if there's any reason why you sitting in this room should be caring about Occupy Wall Street, it's because the 99% turn out to have really different health outcomes and health indicators than the 1%. And we see that both here in the United States, but we see it profoundly in places around the world. And when you realize that women and kids are disproportionately in the lowest group of that 99%, they're in the 70%, they're in that majority of people, that 70% of who is amongst the world's very poor are women and children. Obviously, then the health-related indicators become pretty dramatically clear. What we learned from our perspective as an organization that funded women's rights organizations in 170 countries across the world were that these issues were sort of inextricably linked and connected to one another. So you could no more think about addressing questions of women's health, whether it was HIV/AIDS or whether it was mental health or whether it was reproductive rights and reproductive health, or whether it was infant mortality. You could not separate those things out from questions of how people lived in their communities, how much access they had to jobs, whether it was possible for them to go to school or not, what kinds of access to food and basic nutrition they had. Those were things that were so profoundly interlinked, as were issues of culture and perspectives on what women's roles were in their families. I don't know how many of you may have seen just recently in the New York Times a sort of stunning but very small article about how a young 15-year-old girl was rescued from a house in Afghanistan recently because she had been beaten and abused by her sister-in-law and mother-in-law. Now, I wish I could tell you that this is a, and yes, there were major health issues because she had been beaten up very badly. She had lost her teeth. One of her eyes was blinded. But I wish I could say to you that this was a sort of a unique medical situation. In fact, I think if I would be asked what do I think is one of the major health, the pressing global health issue for women today, it's violence against women. And it is violence at a level and at a scale that although Steven Pinker, the evolutionary psychologist, might disagree with me, I would have to say I don't believe his arguments that violence has actually decreased. He's arguing that as we have progressed into the 21st century, overall violence levels have decreased. I would say that when we look at what has happened with regard to women, in many ways, women's rights advocates would argue that violence against women currently poses the greatest threat to health in terms of overall issues. Why do I say that? I say that because violence and the assumption that violence against women is somehow acceptable and is sort of put aside and is not looked at as kind of being a serious obstacle of any kind is what makes it possible for so many other things to then follow. If you are in a lesser relationship, if there's a big less than sign in front of you, which I think most women end up being born with that less than sign, and I certainly have a personal experience of that, growing up as the eldest of 3 daughters in India. People would constantly say to my parents, oh, you only have 3 daughters. And my father would always say, only as in only what? Well, you have no sons. And then, we'd get into this conversation, which of course I have now suffered from, of my father saying, well, my daughters are every bit as good as any of your sons, which then, I think has led to a little bit of, just a tad of pressure on the other end. But including learning how to not throw like a girl or, not run like a girl or whatever those things are that you're supposed to do. But that less than sign is a very important sign with regard to questions around basic health, because that less than sign starts from the very beginning. So in India today, we have a situation where India is supposed to be shining. We've had these 10 years of fantastic growth rates, between 8 and 10% growth rates. And yet, when the Indian census came out last year, for the first time in India's history since I was born, and that was quite a while ago, 1962, the gender imbalance, what Amartya Sen, the Nobel laureate in economics, called the problem of missing women, was actually worse in today's India than it has ever been in India's history. So here you have a situation where more women are getting educated. India has, quote unquote, now, gotten a significant middle class, and it is precisely that middle class. It is the places in India that are the most wealthy that are committing and using ultrasound technology to commit female feticide and abort female babies because there is such a strong son preference. So that less than sign begins from even before you are born. And then that less than sign profoundly defines women's well-being and health from there on onwards. And you could argue that that less than sign is in fact the beginning of violence against women, because if you don't even want those children to be born to begin with, that is the first act of violence. When they are born, every study that we have from the WHO and every global study indicates that there is profound neglect of girl children across the board, more so in some countries than in other countries. So sub-Saharan Africa, which has such terrible health indicators on a whole set of other issues, actually does somewhat better than India or China or Korea or Pakistan or Bangladesh with regard to how girl babies are treated in infancy as opposed to male children. Then you progress from that and you have forced marriage, the control of female sexuality. So I think, while I said I think violence against women is one of what I consider to be the premier health threats, this is very much grounded in this cultural understanding of less than. The follow-up to that becomes that you end up with a situation where violence then persists through what are considered harmful traditional practices. So whether that is early marriage, whether that is female genital mutilation or clitoridectomies or some other form. Those are all kind of a part of this big less than sign that doesn't allow what Sen calls so beautifully, for those of you who have a chance when you are not being totally subsumed with your medical work. This is a wonderful book called Development as Freedom, and I think for any of you who are interested in working on issues of global health, it's a really important thing. Sen talks about the difference in agency and well-being. So for a long time in the development discussion, as well as I think in health discussions, we've thought about sort of the well-being of our patients, the well-being of communities, the well-being of women and children. And what Sen is arguing, and what I would say many of the women's rights organizations that the Global Fund for Women had the pleasure of supporting and continues to support, is that well-being is not enough. You can provide all the health care that even if you had a clinic in every village, even if women had a trained birth assistant, because maternal mortality continues to be, although it has dropped slightly since last year, although it still continues to be one of the biggest threats to women's health. But well-being alone, without women's personal agency, that means their own sense that they have a right to be in the first place, i.e. their birth was not an accident or a disaster or a misfortune that then they have to spend the rest of their lives overcoming, but then actually that they have voice and place and agency in their lives. I think that's a profoundly important issue for people who are actually working on questions of development, because it means you are allowed to then negotiate the very basic issues around health. What do I mean by the very basic issues? I mean eating. I mean, you have countries, and India is certainly one of them, but I've heard these phrases in different parts of the world as I've traveled and met with women. A woman gets fed after a goat. She can eat whatever is left over on the plate. She eats last after the men have eaten. And between girl and boy children eat less after boys have eaten. So there is this kind of, there is this profound way in which that lack of agency and that sense of having internalized for yourself that you are not worth as much. You should not take up as much space, you should not eat as much, you should not speak as much, you should not demand. That internalization continues to then play out in terms of whether women are included in the smallest of things. And when we were involved with the post-earthquake disaster relief in Haiti, for example, it was really interesting that they were having a lot of trouble distributing food because the buses, the trucks with the food were being chased by large numbers of men in the community. And then they were able to actually work with local women's organizations and shift that so that women were the people who actually got the resources, the food. And they found that this resulted in far more children actually being fed. Now, this is not to say that women are somehow just more noble or worthy or anything like that, but simply to say that because they are used to putting themselves in a position where they take last, they are better able to and have traditionally shared those resources with others. Let me talk about a few other things. So this question of agency, I think, is incredibly important and has made a big difference on issues of sexual and reproductive health. So almost all of the sexually transmitted diseases, obviously, as all of you would know, are diseases that require an understanding around not just basically how do these diseases spread, but also whether and if you have control over the act of sex itself. And if you have a great big less than sign in front of you, then you don't have either control over the act or the ability to make decisions as to in what context, when, and how often you want to have sex and with whom. And I think that that is a profoundly important issue for global health practitioners in every part of the world, because failing to realize that means no matter how many condoms you distribute or no matter how many IUDs you make available, if women are not in a position to be able to even negotiate whether they have sex, how often they have sex, whether it is with their own intimate partners or with multiple partners or whoever it is, it makes it an impossible situation. What do I mean by that? Let me give you one. Yeah, sure. Sure.
Hillary Clinton now, and I'm sure everybody's aware what Sebelius just came out about emergency contraception, but maybe you want to say a few seconds about that and what that
very
means
distressing.
in the United States.
Yeah, so you probably know about this, but the FDA just approved the provision of emergency contraception, the morning after pill for for girls younger than the age of 18, actually younger than 17, as a just over-the-counter drug, as opposed to have it being a prescription drug. And Catherine Sebelius, the Obama administration's head of health, HHS, basically came out against the FDA ruling and said, no, they would not change their current practice, which is to require women and girls younger than 18 to actually have to have this as a prescription. What this does is put the United States in a place where it is, unfortunately, in the company of far less enlightened parts of the world on issues of reproduction and health. And I think that it's a profoundly important statement, because what not having power over negotiated sexual interactions means is that you can find yourself in a position where you are taking the responsibility in terms of actually having life grow within you, and then suddenly you become holy. So until that point, you're just a woman who sleeps around or whatever, but then you're, as a vessel holding a life that is about to be born, suddenly then you become very important for that being born, and then you don't matter anymore. So we've seen this again and again and again in countries around the world where the focus on life being valuable, and that is the argument of the pro-life sectors here in the United States, is that it's a sort of a convenient choosing of when life is valuable. So you don't pay attention to how you're going to take care of that child once that child emerges. You don't provide the circumstances and the support and the policies, but you will implement a reproductive health enforcement like the one that has just been done, to make it difficult for girls who might find themselves in a situation where taking 2 pills the morning after would be both prevent conception and prevent a situation in which future abortions would be necessary, to the situation that we find ourselves in today. The other piece I think I would add to what Michelle said is a place where the United States, I think, is far, far behind many different parts of the world, including parts of the world where we might be surprised that there is that level of openness and tolerance, is on issues of basic sex education. There is very little agreement, and the United States refused to sign the United Nations Convention on the Rights of the Child because one of the sticking points was that the convention requires a commitment to sex education at all levels for children across the board. And in the United States, there is, for reasons that continue to completely baffle me, a deep, deep, deep resistance to the notion that children should actually learn how children are produced, and what the both celebration of your sexuality, reveling in it, enjoying it, being, understanding that this is a source of pleasure, as well as the consequences of it, are simply not taught in ways that are understandable. I think in many other parts of the world, the challenge for women has much more been, and I think this question of sexuality is profoundly important. So if I said, violence against women is one big issue, I would say maybe another, perhaps equally important health challenge for women right now is this whole question of how women's sexuality is perceived. And although I have no idea whether this book I'm about to mention to you has any scientific merit or not, I thoroughly enjoyed reading it, and it's in the Stanford bookstore. So I'm going to recommend that those of you who want to take a look at a different perception on the evolution of female sexuality, look at a book called Sex at Dawn by Christopher Ryan and Cachilda Yetha, Jetha. It's a wonderful look at sort of exploring the myths around the fact that somehow women just don't like sex that much, and so, you know, they just sort of grin and bear it and put up with it. This is the flip side of the, you know, suppression of women's sexuality, is this sort of fear that, well, what if they actually have raging sexual appetites, and somehow we've got to like control them, because that would be a really frightening thing otherwise. And I'm not completely joking about this again either, because if you look at the most harmful traditional practices, many of them are tied up with, literally tied up with, the notion that you have to control and regulate and you know, keep under lock and key, literally, women's sexuality, because otherwise, God knows what promiscuity it could sort of result in. And that's, I think, a very big challenge for women in many different parts of the world. It's also a very big challenge for transgender, gay, lesbian, and other groups, which are also groups that we've worked with over the years at the Global Fund. I'm going to stop because I know we're close to time, and I would love for people to ask me some additional questions. There are two other issues that I would like to mention briefly. I mean, I've talked about poverty, I've talked about violence against women, I've talked about sort of this less than sign and basic inequality. I'm happy to say a little bit more about questions around trafficking, and I would like to say a little bit around the issue of how we understand questions of gender equality rather than simply issues of women being, you know, when we think about women's health, again, I think we tend to put it in a separate box. And I guess I would say human health requires us to, a better understanding of human health requires a deep understanding of both women's and men's health and where they are on that continuum. And also our understanding of sort of what we understand to be male and female. And I think certainly you as doctors, I'm so humbled by the fact that I think we're still learning a lot about, particularly on issues of sexuality, how this can fall along a very wide continuum, so that this whole notion of, you know, women are from Venus, men are from Mars, begins to kind of disintegrate for us when you start talking to queer communities and transgender communities, and you begin to realize that this is a whole lot more complicated than the sort of simple analyses that we would like to, you know, like to put for ourselves. So any comments or questions? I know you folks have a very tight schedule, so. Yes, Michelle does.
You ran the Global Fund for Women for years and raised all this tremendous amount of money to help women have social capital, and clearly socioeconomic determinants of health are so important, which is what I hear you say. But how come women still make 75% on the dollar? And how come, even at Stanford, I don't know if any of you know some of the statistics, the women faculty still make less than the male faculty. So what's going on there for you?
Well, I mean, I think that
5% on the dollar was like 30 years ago.
Yeah, no, and actually it hasn't changed. And actually going back to my earlier comments about poverty, one of the most interesting studies that I think has been done recently is, you know, if you wanted to cut the poverty rate in the United States in half without spending an additional dime in new federal programs or anything like that, all you would need to do is actually pay women equal pay for equal work. That would immediately cut the poverty rate in half. And there are studies that you can see that are cited by the AFL-CIO, and numerous other organizations. Why that's the case, Michelle, I think is part of this larger issue. I mean, I think we have come to a place where we, you know, going back to what my daughter said, where we've come to a place of formal legal equality in certain parts of the world, and not even that in many other parts of the world. But certainly where we live in the United States, we've come to a place of formal legal equality. And yet I think it's always true that culture takes time to catch up with laws. And I think partly what we're engaged in is an unlearning of a set of cultural assumptions around that less than sign, literally that less than sign, which translates into a less than even in terms of how much money you get paid or how much you're worth. But also, I think equally, an unlearning around gender roles that have put as much pressure in some ways on men. And I think that's why I was just ending with my comment that I think unless we look at the pressures that men face in our world today, the ways in which their roles have been constructed, the lack of opportunities that they have to be able to make other choices than the ones that are expected of them, I think we're living in a world where there are very unfair expectations on both sides, actually. And I think a place where we're beginning to try and recalibrate what does that actually mean. And if I would take a very simplistic example of this, it is that, yes, so we as women have kind of so far fought a battle which has been about let us on, let us on, let us on, i.e. to the playing field, or into the operating theater, or into Stanford Medical School, or whatever that is, right? And, other people have done that who've been excluded, right? People of color have tried to play that. Then you get onto the playing field, and you look at the game, and you say, what the heck kind of game is this? And that is the point that I think both women and men and everybody else has to be at in the 21st century. I think we have to be looking at the game and saying, and I feel this way about philanthropy as well, because it's great that we have a situation where people who have become multi-billionaires many times over are being moved to try and address the poverty and the inequality in the rest of the world. But what is wrong with a system that actually allows a few people to have net worths that are the GDPs of like 10 developing countries put together? And why are we okay with a system that continues to kind of perpetuate that? And I think that same question has to be asked on this issue of gender equality also, because I think, I know just from my own example that, when my husband said, well, I would be really happy actually to not finish this PhD and be the one who stays home with our daughter, there was this kind of initial reaction with me. It was like, but that's not what you're supposed to do. Like, you're supposed to, you're supposed to like, let me work. But you're also supposed to make money. Like, that's the thing. That's how it's supposed to be. And there is a lot of inbuilt sets of expectations. And, I see this now. I talk to young people, and they're like, well, she wants to be equal, but then she wants you to pay for dinner when you go out to dinner. So how do we negotiate a world in which we're actually having conversations, honest conversations, even in our personal lives, in our relationships with one another? Because I don't think you can have this big transformative shift, cultural shift, at the kind of macro level, unless you're prepared to do some really hard work at the micro level. And I think we're beginning to see it play out. So how is it that women are disproportionately in medical school, but so few of them are in positions of power and leadership in medical school? Well, turns out there's been lots of research done right here at Stanford. Women scientists spend a disproportionately high amount of their time on doing housework. Disproportionately high amount of their time. So what they should be doing in terms of production of their science, they're taking away. Now, whether they should be or shouldn't be doing that, whether that's self-imposed. I know lots of women friends who are like, oh, he doesn't know how to clean. He doesn't know how to do diapers. So I'm going to do my full-time job, and I'm going to come back and tell him. And I remember the first time I came home from work, and I saw Mira, our daughter. She was, I don't know, 2.5 years old when I started work at the Global Fund. And I don't know, he'd sent her to daycare in some like really frilly outfit. And I was like, Zuli, you sent Mira to daycare in that? Like, I was saving that for, whatever, some party or something. And he looked at me and he was like, if I'm going to do this, I'm going to do this. And it won't kill her to wear that to school. She wanted to wear it, and it's fine. And now I have an 18-year-old who, in many ways, I think, has a so much healthier attitude towards clothes than I did or do growing up, because she grew up with somebody who was like, truly clothes don't make the man. I mean, I just find that to be, I'm sharing this more because I think it's easy to talk at kind of a, at a very high 50,000 feet level about global health and what has to happen and what are the issues. And those are totally true. And yet it is also totally true that what Eleanor Roosevelt said so many years ago about human rights, that where, after all, do human rights begin? In small places, close to home, so small you cannot see them on a map, is also really true. How we raise our kids, how we are in our relationships with one another, how we interact, what our choices are, what we play out in our own lives is as much a statement about what it is we're going to do in our work that I think, and I think you constantly compromise on that. And I would say, Michelle, on the issue of raising money at the Global Fund, I constantly compromised on that too. I mean, I think, you raise money for causes, you care deeply and passionately about. And then you hear, well, but we'd love to give you $100,000, but we don't want it to go to the gay and lesbian groups. Because we don't really understand why women's rights have anything to do with lesbians. Absolutely honest conversation, donor to the Global Fund. And I said, I really appreciate the fact that you want to help the Global Fund, but I honestly cannot tell you that I can take your money and park it in a separate bank account that says untouchable by gays and lesbians, by lesbian groups funded by the Global Fund. That wouldn't be how it works. It would go into the pool, and we would not be like checking your money off against some stream that says, only went to nice girls, didn't go to lesbians. This doesn't work that way. And I think that the whole notion of a hierarchy of human rights that I think we often sometimes have, consciously or unconsciously, in the back of our minds. People have to eat before they can have democracy. People have to be able to have access to a doctor before they can be, before we can have a conversation about gender equality. These are conversations that I think we have to be able to, wherever they are happening, whether they're happening in our personal lives or whether they're happening in our professional lives, be able to stand up and say, no, there is no hierarchy of rights over here. Yes, it is important for people to be able to eat, but Cuba can't justify its fantastic health system and throw thousands of people into jail and say, well, the communist system works in Cuba because we have this fantastic healthcare system. And at the same time, we can't say, sitting here in the United States, where poor people have no access to healthcare, that this is really a democratic country, because it isn't on many levels. If the vast majority of people in this country don't have access to something that is a fundamental right, then we cannot actually with a straight face say that because we have elections, we are democratic. And I think that conversation around sort of situating the question of health inside this larger set of questions about justice, maybe broadly described, is for me a very important thing. It's not something you may necessarily deal with on a day-to-day basis. But I was just sharing with Michelle that my sister is a veterinarian who works in rural India. And one of the things she noticed very early is that although animals are owned by men in the village, animals are looked after by women in the village. And yet every time the animal extension health workers would come out from the government programs, they would never talk to women because they didn't consider women to be knowing anything about animals. And the program that Sagari started with her colleague Nitya was to train women who were in any case actually very knowledgeable about how to deliver a breech calf from a pregnant buffalo, how to take care of what kinds of local herbs worked if there was this kind of an infection amongst the poultry, and put that together with relatively current veterinary medical information and train a cohort of what were animal community health workers. And what was very interesting is that women soon started asking, because they knew a lot about the physiology of animals, about how it affected their own reproductive health, their own well-being, and were there ways in which, and so then there'd be these charts that they would draw to look at sort of, okay, what is the reproductive system of a water buffalo, what is the reproductive system of a woman, how does that work, where does the, what are those changes. So I think there are ways in which we can bring that sort of broader understanding into our day-to-day work, but mostly I think it's a question of consciousness, and hopefully if I've been able to share anything today, it's been able to sort of encourage you to sort of broaden that notion of your own consciousness, and also not to, I think it is important to think about why women have a separate set of challenges, but I think it's important to think about also, if we're going to shift that we also have to look at men and women and their interactions together to be able to kind of, create a different future, which I hope you all will be a part of in terms of, health issues. Thank you.
Any questions at all?
Yeah.
What can we do as clinicians, really domestically, not internationally, but domestically? I'm an infectious disease specialist and did all of my fellowship research on sexually transmitted infections in teenage girls.
Yeah.
And so I just from my own personal experience in educating these women, but we're clinicians seeing.
Yeah. I mean, I think you can be alert to issues around these questions of inequality. I think you can be asking the kinds of questions that, I mean, and now we have a lot more experience in the United States about being trained on issues of recognizing signs of violence, for example, or abuse. I think you can also share what you're seeing in terms of trends and patterns. I think that data is incredibly important. And I don't think it necessarily gets shared with those of us who are in the activist world, for example. I mean, I think people who are clinicians, it's interesting, at the Global Fund for Women, some of our best on-the-ground advisors are women who are doctors in the field, and they get to meet, and they've created a trust situation with so many people in the community that they are often the ones who refer groups to us. So I think that's a very interesting way in which clinicians, now in the United States, I would say the same sort of thing. I think doctors have a very special kind of relationship with students, with patients. And so, patients are able to tell doctors things that, other people wouldn't necessarily get access to knowing. And I know you have restrictions on what you can share, but I think broadly you can share trends. You may not be able to share particulars of individual cases, but you can share trends more broadly. And I think, every discussion about public health helps on that issue.
There's actually a woman in the emergency room. It was so interesting. There's a human trafficking study group that Ellen Stacy's running at FSI. And there's actually someone in the emergency room here that is developing a whole kind of like a mini mental questionnaire on aspects of questions that you should ask to see if someone has been trafficked. And I was really shocked at how many people in our own emergency room have been picked up as, do you want to say abuse?
Well, I mean, the US has a very big issue with trafficking right here, and California is actually a very big receiving location for trafficked persons. And the interesting thing is that they're trafficked not just from outside of the United States, but they're also trafficked from within the United States. So trafficking is a huge issue. And again, these are related. The people most at risk of being trafficked are women and girls who've been abused. So they're running away from abuse in their own home, and that puts them at risk for being trafficked because it makes them vulnerable to people who are offering them love, affection, other forms of security, economic security. And so, yeah, I mean, I think that.
It's like little markers of the family member that doesn't leave the side of the woman. I mean, it's the same
Right.
kind of very similar markers to domestic abuse. But I realize I never asked that of my patients about how much independence of having been trafficked. It's like questions I just never, as a physician,
Yeah.
don't do. So you
Yeah.
say as clinicians,
Clinicians.
there are these things that we can ask.
And I think with young girls, I mean, I think for those, and young boys, I think that's the other place is that pediatricians, I'm really interested in whether pediatricians could be playing a more significant role in terms of, picking up on not just issues of abuse in the house, but also questions about kind of celebrating young people's sexuality, being able to give them space. I mean, I find that there is, if there's no place where children are going to learn this in schools, are there other places where they are being seen by an adult who is not their parent, who can also give them that sense of confidence instead of it being about fear or instead of it being about shame or, and I don't know whether that's a possibility, but I certainly know that, when you do have a great pediatrician, your kid is also better off as a result of it. They have another adult in their lives who they can talk to about things that are important to them. So, but I don't know that that also, it also posits a different way of practicing medicine than the very industrialized, mechanized, I can only see you for 10 minutes, okay, boom, I'm in, I'm out, I'm gone, So, I mean, I think Abraham Verghese is working on that a little bit here at Stanford Medical School, right? He's working on this whole issue of bedside manner and the diagnosis that just involves actually talking to people as opposed to just looking at their charts. But it's hard to do because we live, it's sort of like, I feel like the production of medical care has become like the production of agriculture. It's become industrialized in a certain way, and that makes it really difficult. Yeah. You guys have to go. So anyway, thank you all very much for coming. It was great.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.